Good morning, everybody. Today we will be talking about the diagnosis and management of acute abdominal trauma. These are the points we will be discussing today. We will be talking about the types of abdominal trauma, the anatomical regions of the abdomen, initial care and diagnosis, evaluation of patient with trauma, and then specific organ trauma and surgery. So why talk about abdominal trauma? Because abdominal injuries account for almost 7 to 10% of total hospital admissions. It is present in about 20% of all trauma surgeries. And sadly, half of preventable trauma deaths are related to inappropriate management of abdominal trauma. Extra abdominal injuries are clues to the presence of injuries within the abdomen, and we should suspect abdominal injuries in all trauma. We classify the abdominal trauma into penetrating and blunt trauma. The penetrating, we have the high velocity. Those are the small, fast bullets. And these are the most dangerous because 85% of them penetrate the peritoneum. 95% of these cases need surgery. The low velocity are less dangerous. We have the stab wounds where third of the patient third of these cases do not penetrate the peritoneum, but 50% of these cases need surgery. The blunt trauma, we have the high energy transfer, like car accidents, and the low energy transfer, like fall from height or fights. The diagnostic methods, of course, the thorough history and the physical examination is important. We will be looking for any bruises, abrasions over the abdomen, any pain, tenderness, absent bowel sounds, unexplained hypotension. Basically, we will be looking for any signs of peritonitis. However, the physical examination can be equivocal or misleading, as the peritoneal signs may be falsely negative in 40% and falsely positive in 20%. This is why 10% of all injuries are initially overlooked. Moreover, the physical examination can be unreliable in cases like head trauma, spinal cord injuries, alcohol intoxication, use of illicit drugs, injuries to adjacent structures, and in case of significant amount of blood, and in case of analgesia. The difference between what we are looking for in physical examination between a patient who had blunt trauma or penetrating trauma. In the blunt trauma, it really depends on the mechanism of the blunt trauma. We are looking, of course, for abdominal pain, distension, any discoloration in abdomen or flank, unexplained shock, if there was a bent steering wheel, if there is seat belt signs or any peritoneal signs. In penetrating trauma, we will be looking for any visible injury, including the chest or the abdomen, and of course, abdominal pain, any bleeding, any impaled object, and evisceration, and lastly, shock. These are the anatomical origins of the abdomen. As we can see, we have 9 abdominal origins. And we will be looking for physical signs in each of these areas. I will try just to, so when a patient comes to us with trauma, what are the diagnostic methods that we use after the physical examination? We have ultrasound or FAST, we have the CT scan, we have the diagnostic peritoneal lavage, and the laparoscopy. The focus assessment with sonography for trauma, that's FAST. This is basically to diagnose free intraperitoneal blood, and we use it after the blunt trauma. We are looking for any free blood in these 4 areas, in the perihepatic and hepatorenal space, in the perisplenic space, and in the pelvis. So for pouch of Douglas or rectovesical pouch, and in the subxiphoid area. The sensitivity of FAST is 60 to 95%. for detecting 100 ml to 500 ml of fluid. We can also use the extended fast, and so we can add the thoracic windows to look for pneumothorax. The sensitivity is 59%. Specificity can be up to 99%. This is the looking for fluid into retrovesical and in the pericardium. So what are the advantages of fast? Of course, it's that it's portable, it's fast, there is no radiation, there is no contrast, it's less expensive. The disadvantages is that it's not good for solid parenchymal damage or for the retroperitoneum. So as I said, we usually look for the free intraperitoneal fluid. It can be limited by obesity. It can be limited by bowel gas or by subcutaneous air. It cannot distinguish blood from ascites, and it has high false negative rate. We have the CT in comparison to the ultrasound. The CT is able to define organ injury, of course. It's good for retroperitoneal and vertebral column. It's non-invasive. It's non-operator dependent. It's not great to look for hollow viscous, and we can use it for stable patients. But of course, it's more expensive, and we have complications, especially with IV or oral contrast. The ultrasound, as we said, it's good for solid organs. It can be portable. It's fast, as we said. We can have mediastinum evaluation. We don't need any contrast. However, as we said, it's not. We cannot see well the solid parenchymal injuries and the retroperitoneal or diaphragmatic injuries. We have the problem in case of obesity and gas, and it's less sensitive than DPL. And the ultrasound is operator dependent. Now, the DPL, the diagnostic peritoneal lavage, is the attempt to aspirate free peritoneal fluid. If we have more than 10 ml, it's positive for intraperitoneal injury. The positive test in blunt trauma or stump wound to anterior flank or back, if we have RBC count more than 100,000, and in lower chest stab wounds, we have RBS more than 5,000. This is the technique of the DPL. When do we do the mandatory exploration of abdominal trauma? So in cases of anterior abdominal gunshot, and as we said in stab, not all patients need surgical intervention. In case of stab, we have to do local exploration first, and then we have to determine if there is penetration of fascia or if there is doubt. If there is penetration or doubtful, we will observe the patient. Of course, we will do other diagnostic methods. In case of non-penetrating, we will give tetanus prophylaxis, and after observation, we can discharge the patient. Usually in the non-penetrating, they don't need any surgical intervention. In management of blunt abdominal trauma, there are clinical indications for laparotomy, such as if the patient is unstable, if he has unstable vital signs, and we are strongly suspecting abdominal injury. If there is unequivocal peritoneal irritation, so I'm not sure if there is any injury or no. In case of pneumoperitoneum, if I have diaphragmatic injury, and of course, if I have significant gastrointestinal bleeding, I have to take the patient to the OT immediately. The other complications of the blunt injury, where we don't usually see in the penetrating trauma, are that we have also injuries to other organs, such as spleen, liver, and hollow viscous like the intestine, kidney, retroperitoneal, and mesentery. Of course, as I said before, these depend on the mechanism of the blunt injury itself, in which there was maybe compression, crushing, shearing, or avulsion. So how do I determine how do I do evaluation for the blunt trauma patient? I will do, of course, BB and pulse trend. I will inspect for any seatbelt marks, any skin lacerations, any previous surgery scars. I will do auscultations, palpation. The auscultation will be looking for any silent abdomen, and the palpation will be looking for, as I said, the rebound tenderness, guarding, any signs of peritonitis. I will also do the rectal examination. We will do for rectal tone and the vaginal examination, and we will be looking for any penetrating injuries in the gluteal fold. After that, we will be inserting our tubes. We will do insert the gastric tube, which relieves distension, decreases the risk of unattended vomiting. However, it can induce it, so we have the risk of aspiration. We have to also put in consideration the facial fractures and basilar cell fractures. We will be inserting the urinary catheter to monitor urinary output, but also we have to put in consideration the patient inability to void, the pelvic fracture patients having blood anemia, scrotal ecchymosis, and high riding prostate. As I said, there are sometimes specific organ injuries. For example, we may see spleen injuries. How do we diagnose that? If we see the patient hemodynamically unstable, we may see him with the left upper quadrant pain, left shoulder pain. The CT scan will usually say 70% of spleen injuries. We will put the patient for observation for 72 hours, and the healing takes over 6 weeks. We have a major complication after after splenectomy operation. We call it the OPSI, which is overwhelming post-splenectomy infection. It's less than 1% of splenectomy, and it increases in children. We may have also small intestine injuries. Those are 15% of all laparotomy cases. We need to have high index of suspicious in order to record the small intestine injuries. We need to do serial examination. DPL is usually diagnostic in 95%, and we have increasing success with CT and laparoscopy. The delay in diagnosis sadly increases morbidity and mortality. When do we do damage control? In hemodynamic and stable patient, if there was coagulopathy on presentation or during the operation, if there was severe metabolic acidosis, if there was hypothermia on presentation, prohibitive operative time required to repair injuries, high energy blunt torso trauma, multiple penetrating torso injuries, multiple injuries across the body, if the patient needed massive transfusion, more than 10 units packed of RBCs, and if there was presence of injury, better treated with non-surgical adjuncts. So in conclusion, what we need to say is that the abdomen is the black box. So it is impossible to know what specific injuries have occurred at initial evaluation. The key here to saving lives in abdominal trauma is not to make an accurate diagnosis, but rather to recognize that there is an abdominal injury. Thank you.